Good morning, everyone. Today we'll be giving the neuropathology um, for the month of May. Special thanks to Dr. Gultiki and Dr. Zayat for always helping us with this and taking some time off their busy schedule. So let's do the first case. Do we have Isumeta online connected?
Yeah, I'm here.
Okay, perfect. So first case is a 60-year-old female with a 2-week history of progressive gait difficulty. She reports it's worse immediately after standing and requires a rolling walker. Past medical history is only positive for anxiety. So, Sumet, what other things you might like to know from the history? A patient with progressive difficulty, 64.
Uh, Progressive difficulty. Someone with gait stability. Any signs of kind of like dropping things from their hands.
Mm-hmm.
Any like myelopathy symptoms is what I'm like interested in knowing about.
Okay, good. What other things may be related to like cranial stuff where you like to differentiate if this is something related to her spine or something related to, her brain?
You said that it was somewhat positional, where her gait stability is worse when she stands up.
Mm-hmm.
Maybe is she having headaches? Is she experiencing any double vision, nausea, vomiting,
Exactly.
anything like that?
Perfect. So exactly. So you want to rule out any myopathic symptoms that are causing this, gait instability, and also you want to rule out urinary bowel dysfunction, thinking about some spinal cord tumor or cervical or thoracic compression. And in relation to something happening on the cranial side, you want to rule out any symptoms of increased ICPs like nausea, vomiting, or any headaches. And in fact, this patient had progressive headaches too. Very good. So this is the physical exam of the patient. Basically, it's a normal neurological exam. So a patient with progressive difficulty ambulating and headaches. What type of imaging you want to get, Sumit?
We can start with a CT of the brain or like an MRI of the brain.
Okay,
Something kind of
very good. Okay, so this is the imaging. This is the first couple of slides. And this is the second one. What do you see?
Oh yeah, so there's a large heterogeneously contrast enhancing mass in the ventricle. It looks like it actually uh,
Will you say it
looks like
enhance it? Will you say enhances like vividly or just a little bit? What do you think? Looking at the
it's
left.
at the left one. It looks like so it looks like it's very patchy, like not a lot.
Mm-hmm.
Like it does not
Exactly.
it's not enhancing that a lot that much.
Okay. Very good. What else do you see?
I'm seeing hydro as well. Her vents look a little bit bigger too.
Exactly.
Um, and there's little cystic components in the actual mass itself.
Perfect. Excellent. Okay. Um, so basically, multi-lobulated intraventricular mass center along the anterior aspect of the septum pellucidum within the frontal horn of the right lateral ventricle. And there's, like you said, patch enhancement, although most of the lesion is not enhancing. And most importantly, you see hydrocephalus. Excellent. So any additional workup, any additional imaging would you do in this patient? Try to help you differentiate some of the diagnoses, or
Uh, I mean, there are no spine symptoms, so I wouldn't get
Mhm.
any other neuroaxial imaging. I think I don't. I guess I wouldn't be inclined to get any additional imaging.
Yeah, you're probably right. I mean, some people argue you can do CT to look for classifications. Some meningiomas and neurocytomas have classifications, but in the most, I think with just this MRI, you should be good to go. Um, so what's your differential for this intraventricular tumor?
Based off of it looks like it's coming off of the septum, so central neurocytoma. I'd put on my differential pretty quick, like pretty high. Maybe like
Mm-hmm.
a meningioma, but it would be kind of atypical. Subpendymoma, ependymoma.
Very
Um,
good. What else? How about choroid plexus papilloma? Will you include it on your differential?
It, it could be, but I guess I'm not. I there's not much choroid over there, if any, right? So it'd be very
Yeah,
difficult, but
yeah,
it could be.
exactly. Also, enhancement is not typical, but you can probably just throw it in there for intraventricular tumors. So yeah, like you say, it's central neurocytoma, subependymoma, especially because there's not a lot of enhancement, ependymoma, choroid plexus papilloma, and lower meningioma. But you kind of hit all the differential diagnosis. Excellent. So how will you treat this patient?
Yeah,
Will you treat it? Will you do surgery? Will you do a biopsy? What do you think?
I think this patient, so they're symptomatic. They have
Mhm.
evidence of hydrocephalus. I think surgical resection is the appropriate option for this person.
Okay. And just in general, what type of approach would you do? Would you do cranie? Would you do like, what do you think?
Yeah, so this was one of the resident like res ed points a few weeks back. With these intraventricular lesions, you can do transcortical with some sort of tubular retractor system.
Exactly.
You can also go transcallosal, intrahemispheric transcallosal for these. I guess so cranie, and then enter into the ventricle to remove the tumor.
Perfect. And you use neuronavigation, right?
Always. Yes.
Okay, perfect. Okay, so definitely patients needs surgery. In this case, it's a right frontal craniotomy, and as you said, they use the Vicor cannula system and neuronavigation. And adjuvant treatment depends on what's the final pathology. So, but very good, Sumit.
Okay. Let me share my screen so
Okay.
I can use that. It's okay, please.
Go ahead.
Thank you. Okay, so this is the lesion at low magnification. It is a subependymoma, and this is one of the most important characteristic histologic feature of subependymoma is that at low magnification, as opposed to ependymoma, which is usually a diffuse growth pattern, this one has this nodular growth at low magnification. So this is pretty characteristic. Closer look, you can see that the tumor cells do not have any atypia, pleomorphism, and these are the nodules, and the areas that is hypocellular between the nodules, it's kind of vaguely fibrillary. This is another feature of ependymal differentiation, whether it's ependymoma or ependymoma. Closer look at the tumor cells, no mitosis, no necrosis, no vascular proliferation, which are high-grade features. And the atypia pleomorphism is very minimal, meaning there is minimal variability in size and shape of the nuclei. And Ki67 is also characteristic. It's about 1 to 1.5%. So this is an example of subependymoma.
Okay, perfect. Okay. Very good. Okay. Let me share screen. Very good. So intracranial subependymomas, they usually represent less than 1% of all CNS tumor. They're classified as low-grade, WHO grade 1 histologically. They most frequently occur in the 5th and 6th decade of life. Most cases are asymptomatic, but if they have symptoms, are usually related to ICP issues, like hydrocephalus, tumor hemorrhage, or mass effect on nearby structures. About half of them are located on the 4th ventricle, and then followed closely by the lateral ventricle as the most common location. And they usually do not enhance an MRI with contrast. And on pathology, like it was described by Dr. Stad, there are clusters of isomorphic nuclei embedded on a dense glial fibrillary background. They can have microcystic formations, and they can stain positive for GFAP, NCAM, and they're classified as ependymal tumors, WHO grade 1, along with myxopapillary ependymomas. This is a paper that presents one of the largest series of intracranial subependymomas. They look at least 43 cases that had 5 to 10 years of follow-up. Interesting, about 79% of the cases were misdiagnosed on imaging as some other tumors. And the long-term outcomes on patients that were followed for at least 10 years, the recurrence rate and the survival, the progression-free survival in these patients were close to 90% with gross total resection. So like on our patient, it's the outcomes are very good for patients that have subependymomas. Okay, so next case, Victor, are you around?
Hi, morning.
Okay, morning, sir. So this is a 30-year-old female with a 3-week history of progressive blurry vision. She was evaluated at Bascom and was found to have bilateral papilledema. Past medical history was positive for Ewing sarcoma of the right fibula, and she had resection of that tumor. So Victor, some other things you might want to know about the history of this patient?
Does she have any other signs of perhaps increased intracranial pressure? Has she been scanned for any possible metastases? Does she have any other logic concerns?
So for like symptoms of ICP, you meant like what?
Globally, she could have headaches, nausea, vomiting.
Yeah.
If she has any of those, I think you could also have she could also have some cranial nerve signs as well, depending on the degree of pressure.
Okay, perfect. So you're thinking on the right line, thinking increased intracranial pressure. So nausea, vomiting, headaches. The patient did not have any of those symptoms, and then you want to know if there's any history of metastatic disease, given the history of Ewing sarcoma, and the patient did not have any. This is a physical exam. It's basically a normal neurological exam. And what type of images you liked in this patient, Victor?
Initially a head CT scan to rule out any sort of gross hydrocephalus, and then an MRI with and without.
Okay, good. So these are the images, first slide, then this is the second.
It's a right-sided, well-circumscribed, contrast-enhancing heterogeneous lesion with accompanying edema, gross hydrocephalus seen. Differentials for this would include.
Victor, before you go to differential, do you see anything else on the right image here?
On the right image. There's also another lesion in the that you're circling.
Okay.
Fourth ventricular lesion.
Yeah, a little bit. Yeah, caudal to the fourth ventricle. Okay, very good. So how would you describe these images? You were saying a enhancing intraventricular mass in the right atrium. There's obviously vasogenic edema. Also interesting, there's another small enhancing lesion in the inferior aspect of the fourth ventricle. So will you do any additional workup in this patient with multiple intracranial lesions?
You would do a pan scan, a metastatic workup, just rule out any sort of other lesions anywhere else.
Exactly. And also you can consider doing like a narrow axis scan just to make sure there's no like drug metastasis. So yeah, so med workup and maybe consider narrow axis imaging. Okay, so go ahead. What's your differential?
Well, given her Ewing's, metastasis would be up there, meningioma as well. Also, you could consider choroid plexus papilloma, I think, given the location, and ependymoma too, but that wouldn't be as high.
Okay. Well, very good. So basically, ependymoma, choroid plexus, papilloma, meningioma, and metastasis given her past history. Okay. How would you treat this? Do you surgery, biopsy? Would you treat it? Would you not?
It's symptomatic, so I think that warrants treatment. It's well circumscribed, so I think it is a surgical candidate for a
Okay.
complete resection.
How would you do it? Would you do cranie? Would you do anything else?
Uh, I guess you could do a cranie. You could I think you could also use the Vicol system. I think we use that here at UM.
Okay.
Maybe
And will
that
you
can-
treat the atrial lesion first or the fourth ventricular lesion? What do you think?
Uh, I would go for the intraventricular lesion first.
Yeah, it seems like it's the most symptomatic one. There's a lot of surrounding edema. So yeah, very good. So definitely surgery. In this case, they did right tempoparietal craniotomy, and they also used the Vicar cannula system, and obviously they used neuronavigation to help. And adjuvant treatment again depends on the final pathology. Very good, Victor.
Okay, so this is the tumor. This is the a low magnification. There are a few things that are important to notice here. First of all, the background is kind of myxoidy. There is a lot of vacuolization and bluish myxoid material. The tumor cells are arranged mostly in cords or in lines. So it brings to, into the differential diagnosis, other entities, although the location is very atypical, like chordoid glioma and chordomas and stuff like that. But the imaging and the location argues against it. Closer look, there is no high-grade features, no necrosis, no vascular proliferation, no mitosis, and the atypia and the pleomorphism is still reasonable. And here you can appreciate the presence of this vacuolated background, which is myxoid material. So we have tumor cells that are arranged in cords and embedded within a predominantly myxoid matrix. First things first, of course, we are within the brain, so it would be wise to rule out a glioma. Two stains that we use for screening purposes, OLIG2 and GFAP, are completely negative, which makes the possibility of an unusual glioma very, very slim. The second one is CD99. It is also reasonable to do it because the patient has history of Ewing sarcoma. You want to make sure it's not a metastasis. Although the histology doesn't fit, but you never know. So CD99 is positive, which complicates the story. This histology does not fit with Ewing, but it is CD99 positive. And to make it a little bit more interesting, similar to Ewing sarcoma, the tumor is FLI1 positive. So we have two stains that are expressed by Ewing, are expressed by this tumor. However, the tumor is diffusely Desmin positive. Desmin is a skeletal muscle marker, which is not expressed by Ewing. So this was diagnosed as intracranial myxoid mesenchymal tumor, and we have NGS in process, and it will be interesting to see what are the genes that are abnormal in this particular tumor.
Okay. Okay, so interesting case, intracranial myxoid mesenchymal tumor. They're classified as soft tissue tumor with some sarcoma-like characteristics. They're predominantly seen in children and young adults. Mean age is around 18 years old. Of the few cases that have been reported, mostly seem to be intraaxial or extraaxial, with some in the intraventricular region. They're usually associated with chromosomal translocation, especially the fusion of the Ewing sarcoma breaking region 1 with some other genes. There's no metastasis being reported in the few cases, and usually treatment is complete resection, but there are some reports of disease relapse. This is a literature review that was published last year in Brain Tumor Pathology, and they looked at the 11 cases that were reported to that date. I think the last one I saw was 14 cases that have been reported so far. And interesting about this is like most of these tumors have this translocation that it's associated with the Ewing sarcoma breaking region 1. And then the other is like, even though they have benign features on histology, like half of the cases that have been reported, they have relapse of the tumor within 6 months to 2 years. So I guess it's important in a case to follow the patient closely, because it seems like most of the patients do have tumor recurrence. Okay, next case.
Hold on. This is sorry to interrupt. Does this person have a germline mutation? Does this lady have a cancer syndrome that is the source of these two different cancers in the same?
That we know of, no. I mean, the only cancer she's had before is Ewing sarcoma. It was like 15 years ago that it was resected, and in between this time there's been no recurrence, no metastasis. So, but it's very interesting because it's somewhat kind of related, germline tumors, right? It's Ewing sarcoma, but no history of other tumors or any syndrome that it's been identified. But I guess that's a good question.
Yeah, you could call it bad luck, or you could look. I would encourage you to look.
Yeah, perfect. Will do. Okay, excellent. Next case. Vignesh, are you around?
Yep, I'm here.
Perfect. Okay, so 43-year-old female with a 5-month history of progressive weakness in her lower extremity. She reports that she's unable to walk for more than 5 feet without assistance, and there's no pertinent past medical history. So what are the things you want to know, Vignesh?
I'd ask her if she has any back pain, symptoms of myelopathy, urinary incontinence, bowel incontinence, any sensory changes.
Okay, very good. So you're trying to rule out any spinal pathology, I guess. So you're absolutely right. So you want to know if the patient has any back pain. Patients with spinal cord tumors, large percentage have back pain. And also you want to rule out any myopathic symptoms, upper extremity symptoms to try to localize the lesion to maybe cervical, thoracic level. And always important to ask about urinary bowel dysfunction. This is a physical exam. It's basically upper extremities will full strength, lower extremities she has like proximal weakness, mostly high P's were 0, quads and hamstrings 3 out of 5, and then distally she was like 2 out of 5. Sensation was absent on the left leg, some patchy presence of sensation on the right. No Hoffman, no clonus, no pathologic reflexes seen. So Vignesh, what type of images do with this patient?
I would probably start with an MRI scan.
Okay. What do you do? Like brain, spine,
I would probably
thoracic?
Just based on the localization, it doesn't look like she has a thoracic century level. So I would get an MRI of the lumbar spine with and without contrast.
Okay. I mean, her weakness is proximal, so at least you want to include the lower thoracic. But yeah, something spine related. I agree. So this is the pre-op images. This is the first slide. I'll show you the second now. What do you see, Vignesh?
On the let's see, on the MRI of the thoracic spine, it looks like she has a intradural, what looks like an intradural intramedullary tumor in the upper thoracic spine with the syrinx and cystic component below the lesion.
Okay, very good. So how would you describe, like you said, it's an intradural intramedullary lesion expanding from T2 to T6. There's some cystic components and there's some mild enhancement. And like you said, there's a large syrinx below the lesion. Will you do any additional workup on this patient, or do you think you're good?
I think, I mean, you could, I mean, at this point, I think, you could probably like go into, surgical planning and,
Yeah, I agree. Some
yeah.
people argue neuroaxis imaging and on this kind of tumors, but I don't think in this case it's needed. So what's your differential, Bignesh?
For intradural intramedullary tumors, you would consider spinal epidymoma, astrocytoma, and then less commonly hemangioblastoma, ganglioglioma, paraganglioglioma.
Excellent. So intradural intramedullary tumors, top of the list, like you said, it's going to be ependymoma, astrocytoma, and then lower in the differential is going to be hemangioblastoma and metastasis. Very good. So treatment options. What do you think? Will you treat this patient? Will you do surgery? Would you do a biopsy? Will you not treat it?
I think treat definitely needs treatment. I think surgical treatment would probably be the first line therapy. Depending on the pathology that returns, could consider adjuvant, chemotherapy or radiation, depending on what the pathology returns as.
Okay. And how would you treat it? Would you do like decompression? Will you do instrumentation?
Yeah, I would do a thoracic, like upper thoracic laminectomy.
Mm-hmm.
Probably would not need and then intradural and open the dura, intradural removal of the tumor. I think in the upper thoracic spine, depending on how many segments you take, likely would not need instrumentation. But it kind of depends on how lateral you go with the laminectomy, but likely wouldn't need any instrumentation.
Very good. And what things can you use intra-op to make sure you're doing dissection safely?
Yeah.
Like, what do you use? Yeah.
For sure. I think the two biggest things in this case would be neuromonitoring and ultrasound. Just of course with neuromonitoring, just making sure you have no changes in signals, and ultrasound just to guide with the resection.
Excellent. Very good. You hit those 2 points. Very good. Excellent. Okay.
Okay, so this is the tumor. From the get-go, you can appreciate the presence of what we call ependymal pseudorosettes. So what are ependymal pseudorosettes? They are tumor cells that are palisading around a blood vessel, as opposed to true rosettes, where the tumor cells are palisading around neuropil, where there is no blood vessel. And the tumor is kind of solid with no cystic degeneration or calcification. Higher magnification, this is what we call, the reason we call them ependymal pseudorosette, because the tumor cells recapitulate what they do in the ependymal lining. So in the ependymal lining, the epithelial cells are attached to the underlying ependymal lining by small processes. And here you can see them, but instead of the ependymal lining, you have a blood vessel. So when we do GFAP is positive, not in the tumor cells, but is positive in these processes. So once we see this at permanent sections or at the time when we do a frozen section, this is pathognomonic of ependymal differentiation. Higher magnification to show you the cytologic features, moderate atypia and pleomorphism, but atypia and pleomorphism is not a component of the grading system of the WHO. No mitosis, no necrosis, and no vascular proliferation. which makes it ependymoma grade 2.
Okay. Okay, so spinal ependymomas, they represent about 45% of all intramedullary spinal cord tumors. They're classified as grade 2, WHO grade 2 of ependymal tumors. Complete resection is associated with improved progression-free survival and overall survival outcomes. And usually radiation treatment is recommended for grade 3 ependymomas, either with subtotal resection or total resection. And for grade 2 ependymomas treated with subtotal resection. Here's a study published this year at the Journal of Neuro-Oncology. And they look at long-term outcomes of spinal ependymomas. They look at 60 cases that had at least 5 to 10 years of follow-up. And like our patient, interesting, patients that have grade 2 spinal ependymomas that undergo subtotal resection, which is the blue line here, plus radiation therapy, have increased progression-free survival and local control when compared to patients that have subtotal resection of grade 2 ependymomas with no radiation therapy. And I think it's close to 87% compared to 50% at 10 years. So important, like in our patient, if there's even if they have subtotal resection, the patient should undergo radiation treatment. And we have to be aware of this to refer them to the proper place. Okay, last case. Eva, you around?
Yeah, I'm on.
Okay. Yeah. Dr. Levy?
I don't know if that's, if we can go back to the paper, I'm not sure that that's the right conclusion. I don't know what the right conclusion is. I'm certainly not a proponent of that. I think that if someone has a very, very small residual, probably less than 10% of the tumor being there, and because the tumors grow so slowly, I haven't been radiating them in those circumstances, and many don't have any progression, and some who do often are good candidates for re-resection.
Okay.
So I'm not sure what the right answer is. I'm very, they're very slow growing. Radiating them has a lot of downside, especially if you're planning on potentially reoperating on them. And I don't know if that this proves that the radiation is biologically active, because I'm sure that these tumors were so heterogeneous in how much residual there was, et cetera.
Exactly.
And they're so slow growing that even though they have a relatively long follow-up, I think the number of cases that have true more than 5-year follow-up based on those little dots is extremely little. When you look at the dots, those probably represent each cases. So I don't know if I believe that. I don't know if Dr. Green or Dr. Raghav or any others have comments on that.
Yeah, Dr. Levy, definitely they did not specify, what was left of the tumor. So they don't enter into that detail. So, but that's a good point. It depends on what's the residual, if there's going to be planned for further resection. Yeah.
And I worry that this sort of says, okay, do a biopsy and then radiate, which is not the right decision.
Yeah. We haven't had, Alan, I agree. We haven't had happy endings with radiated patients, and I think the growth is very slow and it's even variable. So I would not recommend the radiation either, unless that was the last alternative.
And
Perfect.
the only thing I would add to that is that if you look, there are historical series that are much larger than this. and they have shown the opposite result with respect to radiation. And I would encourage you to look at those before you change your practice pattern.
Good point.
Give us
Thank you.
more details, Dr. Ragab. I'm not sure what you're talking about.
There's a very Epstein wrote a very large series many years ago of over 100 patients, and my memory of that series, and we can certainly dig it up, is that radiation was not associated with improved long-term survival, and it was only used as a salvage treatment for those that were widely metastatic and recurrent. So the role of radiation is very limited in spinal ependymoma. It's different in fourth ventricular ependymoma and hemispheric ependymoma. You can argue that one. I think the other thing which is going to have an impact ultimately is the characterization of these beyond histology, because there's a great deal of variability with intracranial ependymomas based on their genetic expression. And ultimately, I think we're going to understand the disease better if we can characterize them based on their genetic expression.
Excellent. Okay. So that's a good point. Thank you. Okay. So let's go to the last case then. Eva, you around?
Yeah, I'm still here.
Okay, perfect. So 74-year-old male with a 6-month history of progressive left leg pain. He reports pain as stabbing in nature. He failed gabapentin treatment, and he feels a bump in his left anterior thigh. Past medical history is positive for prostate cancer, hypertension, and he had a radical prostatectomy. Some other things you might like to know, Eva?
Yeah, is he having any like back pain? Is he having any motor weakness? Is the pain in his leg like more like radiculopathy?
Okay. How about related to the bump in his left
and then the
anterior
bump,
thigh?
I guess. How long has it been there? Is it hard?
Uh-huh.
Mobile? Is it
What-
mobile, or does it feel like it's stuck?
Okay. Very good. What else would you ask if a
Oh, yeah,
patient?
like bowel, bladder incontinence. So I guess because he had that bump, it could be like something like neurofibromatosis. So you would look for like cafe au lait spots if he has any other cutaneous neurofibromas anywhere else, like Lish nodules, like axillary freckling.
Very good. So you want to rule out some like, spinal cord things like back pain, radicular symptoms, urinary bowel dysfunction. And then because of this bump, you want to know if there's, you start thinking about peripheral nerve sheath tumors. You want to know if there's any bumps, if there's any cutaneous manifestations like an NF1 and any other family history of similar lesions. But he had none of those things. Physical exam, it's completely neuro intact. So what kind of images will you want this patient with left leg pain and anterior thigh bump?
So for the bump, I would just get an MRI of the left thigh with and without contrast.
Okay, very good. So this is the first slide of images, and then this is the second one. How would you describe it?
Yeah, it looks like it's a contrast, or kind of heterogeneous contrast enhancing lesion that's in the left thigh area. It looks like it's pretty well circumscribed, kind of tracking along the nerve root.
Okay.
Or sorry, not the nerve root, just the nerve.
The nerve. Okay, very good. So basically a heterogeneous enhancing craniocaudally oriented mass. It's below the left vastus lateralis, sorry. Seems to be cystic in appearance, and there's a central relative low signal T2, which is suggestive of target sign. You can see here it's seen on benign peripheral nerve tumors. Okay, Eva, what's your differential?
So the differential for this would be neurofibroma versus schwannoma, and less likely like malignant peripheral nerve sheath tumor, given he has no motor deficits.
Exactly. So you are inclined that this is a benign lesion because of the symptoms, right? What
Yeah.
would you expect in a benign peripheral nerve sheath tumor?
Just, I guess, like pain, or like pain wherever the.
No, but related to symptoms, you were talking about it, motor, right?
Oh, you mean if it was malignant, you would
Yeah,
expect
is it
motor weakness
malignant?
and like paresthesias.
So if it's malignant, how it's going to be different from a benign lesion in respect to timing of the symptoms?
Oh, it's gonna be more like rapid onset.
Okay, and what symptoms will have, would you see in the patient with a malignant lesion? Would it be pain or would it be what?
It'd be like paresthesias,
How about motor symptoms? Will you see them on the
and then like
benign?
motor weakness. Yeah, like motor weakness and like paresthesias and malignant tumors, and that's acute onset.
Exactly. So in a patient that you have that presents with severe pain, rapidly progressing symptoms like motor weakness, sensory deficit, you will start thinking about more malignant lesion, right? Very good. Okay. This is a differential. How will you treat this patient? Will you do surgery? Would you just do biopsy?
So I would just do a surgery to excise the lesion, because if you biopsy and it's malignant, then you might see the tract.
Yeah, exactly. And then the other thing, it seems like this is a benign lesion from the history. Also, if you try to do a biopsy in patients with benign lesions, you can injure the nerve root, or I guess the nerve that's involved in the tumor, and they can have the deficit after that. So you'll do a surgery, right?
Yeah, I would do surgery for it.
Okay, perfect. Very good. Okay. And some of the things you can use intraoperative nerve stimulation to make sure when you're doing the resection that the nerve fascicle is not functioning. And if there's any other nerve fascicles that are functioning, you can dissect them away from the tumor. And radiation chemotherapy depends on the final pathology, but most likely in this case won't be needed. Very good.
What nerve is this arising from?
Let me put the images.
Lateral femoral cutaneous nerve, maybe.
Not a bad thought. I mean, it's definitely not a major motor sensory nerve, given its superficial location. It looks like it's located in one of the quadriceps muscles superficially. So I suspect it's sensory. I don't think it's actually lateral femoral cutaneous, because those are typically in the subcutaneous tissue, and this is actually kind of partially embedded in the muscle. But I suspect it's a distal branch of the femoral nerve.
Yeah, that's right. Very good. Perfect. Okay, let's go pathology then.
Okay, so this is the tumor. At low magnification, you can see that the tumor is very well circumscribed, which is an important feature because the vast majority of malignant processes, not all of them, of course, but the vast majority of them are not well circumscribed, but rather they have infiltrative borders. Cytologically, or histologically first, you can appreciate the presence of what we call Antony A, Antony B. Antony A being the area that is hypercellular, Antony B the area that is hypocellular, and there is a vague Verroquet body here, which is palisading of tumor cells around around an acellular area. Closer look, the tumor cells show no atypia or pleomorphism, so MPNST is not a consideration here, and SOX10, which is a pan-neural marker, is positive. So it tells us this is either a neurofibroma or a schwannoma. We favor schwannoma, but to make sure, this is from a different case, I'm just going to show you neurofilaments. So this is in a neurofibroma. Remember, neurofibroma is a tumor of the nerve itself, and therefore you would expect to see some entrapped axons, and that's why neurofilament will be positive in intralesional axons. However, in schwannoma, since schwannoma is a tumor of the peripheral nerve sheath, not of the nerve itself, you will not expect to see and trapped axons within the tumor. So neurofilament is very helpful. So this is an example of a schwannoma grade 1.
Very good. So the last neuropath I talked about schwannomas. So I decided to talk about neurofibromas and how they differentiate from schwannomas. So neurofibromas, they usually represent 20 to 30 years. They present around 20 to 30 years of age. Males and females are equally affected. And compared to schwannomas, they have a less well-defined capsule. And that's why Dr. Saad was referring to the first slide, where schwannomas do have a well-circumscribed capsule. And they have multiple fascicles entering and exiting the lesion compared to schwannomas. And also the nerve of origin is usually non-functional on presentation. So usually you can just sacrifice that nerve fascicle when you're removing a neurofibroma. They're subclassified depending on their growth pattern. They can be either well demarcated, or they can have diffuse infiltration, especially at extraneural sites. And they can have a plexiform variant. They're the hallmark of NF1, and they usually occur in childhood or adolescence after the detection of café au lait spots. Just to review the criteria diagnosis of NF, usually 6 or more café au lait spots, and depends if you're pubertal or post-pubertal. The diameter is 5 millimeters versus 15 millimeters. 2 or more neurofibromas, or 1 plexiform neurofibroma, axillary or inguinal freckling, the presence of optic glioma, 2 or more lesion nodules, distinctive osseous lesions like sphenoid dysplasia, or any first-degree relative with NF1. In contrast to schwannomas, neurofibromas show proliferation of all components of peripheral nerve. They have the presence of axons within the tumor that help distinguish a neurofibroma from schwannoma. And on immunohistochemistry, they're positive for S100, but less frequently than schwannomas, like it was in this presented of this case. Also, I was trying to look at any new research on neurofibroma, and I came across this article from New England Journal of Medicine from last year, and they were looking at different treatment modalities in respect to medications for patients that had inoperable plexiform neurofibromas, and they target different proteins in the RAF MEK pathway, which is effective in patients with NF1. And they look at specifically a MEK inhibitor, which is called selumetinib. And they looked at 40 patients with at least 1 to 2 years of follow-up with this treatment of MEK inhibitors. And 73% of the patients had tumor control, or tumor volume that was at least decreased by 20%. And there's 2 examples here in patients that were treated with this MEK inhibitor. And you can see there's a large left plexiform neurofibroma of the neck. And after 1 year of treatment with this drug, they had at least 25% decrease in the tumor volume. And most importantly, this patient had more clinical findings were positive, like more degrees of neck extension, neck flexion, shoulder movements. So this was positive for at least this patient. And then another patient that had a big neurofibroma of the neck, again on the right neck area, after 13 cycles and 6 months of treatment, the patient had at least 40% decrease in tumor volume. So for me, this is kind of interesting to see that there's now targeted treatment for different neurofibromas, and there's a lot of clinical trials that are going on, and it's exciting for this patient population. Very good. That's it.
Thank you, guys.
Thank you.
Roberto, I just want to comment on that last part. The MEK inhibitors actually are also having some promising results in NF2 patients as well with bilateral acoustic neuromas. And there's some clinical trials ongoing with that, but it's not a homogeneous response. It's not in everybody. And so there's still a lot of research undergoing. What are the specific molecular pathways in each patient? But it is promising, like you said, to have some kind of medical treatment for these patients who otherwise would not have anything.
Wow, interesting. Thank you, Dr. Ivan.
Okay, so if we're ready, I'll go ahead and get started. Everybody hear me okay?
Yeah, we can hear you and we can see the presentation.
You can or can't see it?
We can.
Okay, great. I'll get started then. Last year I talked about head trauma in sports, and that seemed well received. So I wanted to build on that this year to review some other neurosurgical conditions that uniquely affect athletes. I'm going to review some of the salient points from the CTE talk because I do think that those concepts are important to understand. But like I said, there's going to be a number of other conditions I wanted to go over because I think it's important to think about how they affect athletes. And specifically those that affect athletes uniquely. So, why is this something that we should care about? What's the relationship between sports and neurosurgery? And what if there's no neurosurgical treatment? These are all kind of questions just to keep in mind as we go through these topics. So, a typical neurosurgical case could be a 45-year-old with history of opioid use, multiple microdiscectomies, ALIF, and chronic back pain. I think everyone knows that's Tiger Woods. And then the picture there at the bottom right is when he won the PGA Championship in Tulsa, Oklahoma in 2007. I was there, and it was one of the coolest things that I've ever seen. Not my picture, but very cool. There's a lot of patients out there like Tiger who have a neurosurgical condition, but it's not necessarily unique to an athlete, right? This could be any of our patients, even if they haven't won multiple masters. And so Tiger's not the, even though I'm a big fan, not the purpose of the talk. I want to focus on conditions that affect athletes uniquely, but I wanted to include this slide to basically say that, obviously any athlete could have any of the conditions that we treat. So why should we care about how neurosurgery is related to sports? And the reality is that as neurosurgeons, we have a unique understanding of some of the pathology that can uniquely affect athletes. As a case in point, I'm not going to dwell too much on the history of CTE, but I think it's an important point to make. You know, it's was described in the literature 100 years ago. It's not a new phenomenon. Even if you look back at these old papers, they had a very good understanding of what happened when someone sustained a concussion and what ensued. This is from a pathology textbook that was written back in the 70s. They describe the changes that are seen on pathology in someone with chronic repetitive minor blows to the head. And you know, all this is interesting. Why? Well, because this really wasn't something that became of interest in the public eye until the 1990s. There were a few very well-known NFL players who essentially had significant cognitive decline and just kind of a tragic personal lives after they retired from the NFL. So in the 90s, the NFL created the Mild TBI Committee to investigate the impact of multiple concussions, really as if there wasn't 100 years of research that already documented what happened with repetitive subconcussive blows. So this is 1994. You know, the NFL commissioner who created the committee appointed one of the team doctors for the Jets to lead the committee. And everyone at the time was saying, well, you know, concussions are a risk. We don't really know how many it takes to affect someone or why some people are affected more than others. Eventually, over the next 10 years or so, you know, this became a bigger and bigger issue. You know, kind of the NFL still saying the same thing. We see people all the time that get knocked down briefly and have no symptoms, no long-term sequelae. Interestingly, the committee in 1997 rejected the American Academy of Neurology's return to play guidelines, citing a lack of research to support those guidelines. So, you know, a little more backstory on this. The person who was in charge of the MTBI committee for the NFL for a long time was a team doctor for the Jets, who's actually trained as a rheumatologist, and he tended to downplay any study that raised the possibility of risk with repetitive head trauma. He even published a guest editorial in our neurosurgery journal in 2003. Then I think a lot of people at this point have at least heard about this movie. Will Smith played this pathologist, Dr. Amalu, who was a neuropathologist working in Allegheny County. He did an autopsy on a single NFL player and essentially published his findings, also in the Neurosurgery Journal. He went through some of the common characteristics of CTE, pallor substantia nigra, diffuse amyloid plaques, neurofibrillary tangles, and then none of the other features that you would expect with the other common neurodegenerative disorders. This was published in 2005. You know, obviously the conclusions that could be made were limited. While there was a lot of research on minor head trauma and how that affects people, this was the first time someone actually looked at it in an American football player. A lot of the work that had been done before was looking at boxing or people from other occupations where they sustained repetitive head trauma. You know, the work gained some traction, but was rejected by the NFL as it was just essentially amounted to a single case report. But then over the next decade or so, more and more of these studies were done, and it eventually became too big to ignore, essentially. So, you know, I think the significance of this vignette is that, you know, neurosurgeons, should be involved in neurosurgical problems. We have a unique understanding of the brain and what happens after a head trauma. Had there been a multidisciplinary approach to understanding this problem early on, I think that it's likely that the game would have been safer for players sooner than it was. And now, fortunately, the approach to head trauma in sports does involve a multidisciplinary approach. Neurosurgeons, sports medicine doctors, neurologists, trainers, and coaches are all now involved in recognizing when this happens. So just again, kind of coming back to our goals and the things to think about, when it comes to dealing with neurosurgical problems, sports or not, if we're not involved, someone else will be, and it will likely be someone who is not as experienced or qualified to be dealing with these issues. So a little more about what goes on in CTE. As I said, I would bet that our residents have more experience managing severe and moderate head trauma than any other clinical team in the hospital. We see it all the time, and this is really helpful because a minor TBI versus a major TBI, it's the same process in a lot of respects is going on, just on a different scale. Mild TBI or concussion is thought to be a mild multifocal axonal injury. It's just rather than having a shearing of axons, you may just have some swelling and edema that temporarily stuns the tissue. They've done autopsies in patients who had recent concussions before they passed. They did see activation of inflammatory cells and also small hemorrhages. So this is just a nice diagram of what happens following a minor head trauma. You have disruption of microtubules, and notably you have leakage of calcium into the extracellular space, and that's what really drives a lot of the pathology and the secondary injury that occurs after a head trauma. And one of the hallmarks of CTE, as we know, is the buildup of neurofibrillary tangles and tau protein, and this is related to essentially the breakdown of microtubules. And this is what that looks like on a path slide. You see the arrows there pointing to neurofibrillary tangles that have built up in the, I believe that's in the temporal lobe of a former professional football player. On the left, you can see an example of axonal swelling following head trauma, and then the activation of inflammatory cells on the right in the perivascular space. And then over time, with this happening chronically, you can get amyloid deposition within the blood vessels in the brain, and also the buildup of hemosiderin related to the chronic bleeding. Ultimately, you have chronic inflammation with reactive astrocytosis, which you see on the left. And then finally, the buildup of tau protein within the cortex. This is another slide that I just think gives a nice overview of what happens following a head trauma. As I mentioned before, the influx of calcium into the extracellular space, you have the development of free radicals, which ultimately lead to damage of the cell membranes, which really drives the degenerative process. Also important to remember that while the trauma is a necessary part of developing CTE, it's generally part of a overall sort of clinical presentation rather than the only thing that drives it. You know, stress, substance abuse, and chronic pain are very common in people with CTE, and certainly exacerbate those symptoms experienced by those patients, and really tend to drive the process forward. And I think that this is a really nice figure that shows sort of why this happens in people with repetitive head trauma and not it's someone who's had 1 or 2 concussions. And it also explains why some people can play contact sports for years and years and never show any long-term sequelae, and then there's some who can play for a couple years and be very significantly affected. As with other neurosurgical conditions, including stroke, there's this sort of concept of cognitive reserve. Some people have more than others, and that can be driven by age, substance abuse, and just kind of their baseline threshold for dementia. And injury over time pushes people closer and closer to that threshold, wherever it is. So when we're talking about CTE, the only recognized means of diagnosis is on tissue pathology. So it has to be diagnosed on autopsy. MRI does not reliably diagnose it. There's some studies that have looked at using PET MRI to diagnose it. That's still under development. Clinical suspicion is based entirely on symptomatology. So what are the symptoms? They're listed here: memory loss, confusion, impaired judgment. I'll go to the next slide. I think this is more helpful because it shows how frequently they happen. It's worth noting that in mild CTE, the mood symptoms tend to be more common, whereas in severe CTE, a progressive course is really the most important distinguishing feature. Cognitive symptoms also being a big part of severe CTE, and to a lesser extent in mild CTE. So it just to make a distinction with the terminology, CTE, as we said, can really just be diagnosed on pathology. So to be completely politically correct, people also will use traumatic encephalopathy syndrome to diagnose the clinical syndrome in a living person. So who is at risk? I think obviously American football players, but also boxers, hockey players, and notably soccer. People are finding it's more and more prevalent in soccer. The act of heading the soccer ball it could certainly be with consequence. If done many times over many years. Obviously, people who've sustained blast injuries and people who've been abused also at risk. In terms of management, it's really all aimed at symptomatic therapy. There's obviously no treatment or any way to reverse the process once it's started. Patients tend to have a lot of chronic pain, as I mentioned earlier, so that's an important part of managing the problem. And the mood disturbances also are generally treated as you would treat any type of mood disorder. Also worth evaluating endocrine for endocrine dysfunction in these patients. It's common, which makes sense. We see this in our head trauma patients that are admitted inpatient, not infrequently having endocrine disorders. And in severe cases, patients can have vestibular and ocular dysfunction and may benefit from eye tracking and gait training exercises, and in really severe cases can even require prism glasses. Exercise is very important in people with suspected CTE. There's actually been several studies done, like the one shown below, that shows that when patients are who have CTE exercise, they actually have more activation of salient attention networks within the brain when performing higher cognitive functions than those who don't. And that makes sense. We know that the kids who exercise tend to perform better on tests. So it follows that would work in this situation as well. So, important takeaways on treatment. Again, there's no curative treatment, nothing that can be done to stop the process. So the most important thing is to try to prevent it from occurring in the first place. And fortunately, at this point, we have a pretty good idea about how we can prevent CTE. And there are some things that have been put in place in sports at the highest level to do that, and I want to spend some time on those. So, helpful to think about the types of forces that occur in TBI. I like this figure a little better. You think about a linear acceleration versus an angular or rotational acceleration. Rotational is definitely the more devastating of the two. You think about the brain as essentially just floating in CSF within the cranial vault. It does a reasonable job of protecting itself with a linear stop, less so if there's a rotational twisting sort of stop motion of the head. And this has to do with what anchors the brain into place, which really is essentially just the tentorium and the falx and the cranial nerves and the bridging veins. So one of the things that can be done to prevent this is better technique, better coaching. And this will be a theme in a lot of the different types of sports injuries that I'm going through. A lot of these can be avoided with good coaching, good technique, and good referees to recognize when someone is not playing safely. And this is actually is not just like an idiom. I mean, this has been validated in a number of studies. I mentioned one here that analyzed 70 players with GoPros to essentially analyze their tackling technique, and they could accurately correlate tackling technique with who sustained a concussion throughout this season versus those who did not. And again, the most important way to prevent CTE is to recognize when someone's had a concussions. And I think that Dr. Cantu in Boston puts this nicely. While the number of concussions is relevant, it's really the proximity of the concussions in terms of days to weeks or months that will determine the duration of the signs and symptoms that they have as a result of the concussion. And this is because there's a proven dose-dependent relationship between cognitive decline and number of concussions. So number of concussions matters. And those who had 3 or more concussions in a separate study were 3 times more likely to have more concussions. So risk of concussion goes up with more concussions, and the cognitive decline will correlate to the number of concussions. And I think that this is really interesting. And this is from humans. When someone sustains 1 concussion, they're 3 times more likely to have one that during that season. So that's kind of the third tenet of preventing CTE, is that this sort of where these concussions happen in relationship to one another, how much time passes in between is really important. And the reason for that is shown here. So, there's sort of this window of vulnerability following a concussion or a mild TBI. I go back to this slide, just again thinking about the inflammation that happens after a head injury. You have free radicals, you have swelling, you have decrease in perfusion and nutrition. The brain's in a hypermetabolic, hyperglycolytic state, and so there's this window of susceptibility. If that is not allowed to go back to normal conditions, then you can really get this cumulative effect, like what you see on the right. And the patient may, when that happens, never go back to what the cognitive baseline was before it ever happened. So, how is concussion recognized? I think most of us on the clinical side are familiar with how to assess mental status. It's just important to know that headache, while it's the most common symptom of concussion, it's not necessary to diagnose someone with a concussion. Also, this concept that like having a concussion means that they got like knocked out is not true in most cases. Only in about 10% of cases do people who've had a concussion actually lose consciousness or get knocked out. So for mental status assessment, very, very standard questions like what we would ask any of our patients in the ER to assess their mental status after a head trauma. You know, where are you? What city are we in? Do you remember what happened? What day is it? What month is it? And you can also test language, test memory, ask them to count backwards starting from 10. These are all validated methods for assessing mental status on the sideline. And I also wanted to take a second to go through the NFL's protocol. You know, certainly a lot of our faculty are on the sidelines in these local NFL games and are probably well familiar with this, but it basically takes one of three things to trigger the assessment of a player. So, you know, if there's an impact to the head and the player seems to be not acting normal, or essentially if anyone else on the field, an official, coach, somebody in the booth, that any of them can call down to the field or say they think the player needs to be evaluated. So once the evaluation's triggered, any of the red flags automatically exclude a patient from returning to play. So if there's a loss of consciousness or seizure, motor instability, obviously, or if the patient's at all confused or amnestic, then they would be barred from returning to play that game. If none of those is present, then you can do a focused neurological assessment. So this would be check for cervical motion tenderness, evaluate speech and gait, and then the Maddox questions, which are essentially the same questions we just went over on the previous slide. And if those are all normal, then the player is allowed to return. If there's any question on any of those, then the patient's taken to the locker room for a repeated exam before being allowed to return to play. And the sideline survey is usually the one that they do kind of there'll be like a little tent on the sideline, and the broadcasters will usually say that they're going to take the player to the tent for an assessment, and that's what's going on there. And that's the overall sort of paradigm the NFL uses, and it seems pretty reasonable in light of what we know about head trauma. However, important to recognize that these tests have inherent limitations, and you have to recognize. And I remember last year, a few of the faculty had mentioned to me, you know, the athletes have ample incentive to be untruthful about their symptoms, you know, especially in these situations. You're kind of the bad guy and not the good guy, because nobody wants to be told that they don't want to play. It's not even just about they enjoy their sport and want to play it. I mean, it also is is a career that they've worked hard for. It can be the difference in millions and millions of dollars whether they're able to re-sign a contract or lose it, or even at the collegiate level. It could be difference in scholarship and so on. So there's plenty of reason that an athlete would not be super cooperative on this exam, and so it really is on the clinician to recognize that and try to do a truthful assessment regardless. I think that this is interesting. There's some people have proposed some more objective measures of testing, and there's one that tracks eye movements with an iPad that is been shown to reliably recognize when someone had a concussion. I think tools like this could certainly have a role in the future in evaluating someone who's had head injury, because again, it's objective and it doesn't rely on the patient to tell you what their symptoms are. So once someone has had a concussion, once that's been established, what's the process for them being allowed to play? Are they allowed to return to play? So in general, if it's the first concussion, or if it's someone who's not had a concussion in a long time, the patient will rest, usually a week, sometimes 2 weeks or more if it was a severe concussion. And it's a graduated process to return to play. So, it'll be complete rest, taking it easy, no stimulation for the first week or so, and then starting back with light exercise, which would be like riding a stationary bike, onto heavier exercise, which could be running, and then eventually football specific drills and contact specific drills. And, if the patient exhibits symptoms of concussion at any step along the way, then they move back to the step that they were at before they started having those symptoms. When to obtain imaging, I think this is fairly obvious. I mean, if there's a seizure, progressive symptoms, or any outward evidence of a skull fracture, then someone should have head imaging done. And then I also thought that this was interesting. The NFL actually does cognitive testing at the beginning of the season on all the players. And so that way they have a baseline that they can use throughout the year if there's a concern that someone has had a significant head trauma. So, just to kind of recap, and this is really I think the most important takeaway when we're talking about CTE. It's certainly a disease that can be prevented, and I think that even in the setting of contact sports, if you have proper coaching and you have trained personnel on hand to recognize when someone has sustained a head injury and to remove that individual involved from play, it certainly keeps the sport safe. I think that there's a lot of promise in some of the other tests that are being published that could also be used on the sidelines to help even untrained medical personnel to recognize when someone should be removed from play. So prevention dependent on early recognition. Again, that's the takeaway point there. And so next, I kind of want to go through some other neurosurgical conditions that as I mentioned earlier, really tend to affect athletes uniquely. And there's not really a textbook on this, or it's not necessarily a board topic. So the way that I kind of put this list of conditions together is basically I went through all the topics that I could think of that we see in neurosurgery, and then just looked at what information was available in terms of who among those patients can play sports or has played sports, what the outcome was, you know, and also what the experts have said, what the guidelines are. What I tried to stay away from is, you know, there's like single case reports out there for basically every sport and every neurological condition. And I don't think that those are super helpful, because you can publish a case report that says, you know, oh, so-and-so had this and they played this sport and it was fine. But what like meaningful information are you getting from that? How are you actually going to use that information in clinical practice? It would be pretty limited. So I just went through, this is a list of conditions that uniquely affect athletes, and that there is some, at least some expert opinion or some substantive research that's been done about this. And I'm just presenting what's been published. I know that a lot of our faculty have a lot of experience treating these conditions. So if anyone does have any further guidance on these topics, it's certainly welcome. So some general concepts for neurosurgical conditions affecting athletes. Most of the intracranial abnormalities that I looked at do not bar someone from participating in sports indefinitely. There are some spine conditions that need to be recognized because they absolutely prohibit safe participation in sports. So this is one that's fairly common. We see arachnoid cysts all the time. Incidence is not well known, probably around 5 in 1,000 based on several large-scale autopsy studies that have been done. And if they're asymptomatic, we rarely intervene. You know, interestingly, some sports organizations actually bar patients who've been diagnosed with arachnoid cysts from participating. And this is, of course, because these patients are thought to be more likely to have a subdural even with a minor head trauma because of the fragile vessels within the cyst wall. And this is well documented, actually. There's a lot of case reports and papers out there about people who've had arachnoid cysts, had some kind of minor head trauma, and then developed a subdural. So how do you decide which sports are safe to play with an arachnoid cyst? Well, the group at the University of Michigan actually did a really nice study on this. So they looked at 185 pediatric patients with a known arachnoid cyst, followed each of them for a mean of 16 months. 115 of those played sports, and 94 competed in contact sports. And the list of contact sports they competed in is there. I did not know also before I read this paper that ultimate frisbee was a contact sport, but for the sake of this study, it definitely was. And this is a breakdown of the sports that they played: soccer, basketball, baseball, the most common, but also a good number of football players. You have breakdown of the location of the arachnoid cyst. Not surprisingly, middle fossa is the most common. So they found essentially that there was no significant difference in the patients who required surgery with respect to sports status. Of patients who played sports, and that includes contact sports, only 2 experienced neurological symptoms, not including concussion. And that's important. I'm going to come back to that in a minute. But there were 2 patients who developed subdural hygromas that resolved without surgical intervention. Their symptomatology was essentially just headaches. So their recommendations were that no patients had any lasting neurological deficit as a result of playing contact sports. The reality is that, you know, these patients probably are at higher risk for developing a subdural and becoming symptomatic after head trauma than someone in the general population. But the evidence that's out there suggests that the likelihood of that happening, even in contact sports, is still very low. So Next, I want to talk a bit about shunt and what type of recommendations do we give patients with shunts regarding what types of activities they could participate in. You know, obviously a fastball thrown by the big unit striking the shunt system would certainly deem it dysfunctional. But most of our patients probably aren't going up to bat against Randy Johnson. So how do we counsel them? Shunts are obviously very common in some countries, up to 150 per 100,000 bursts. The consensus generally is that normal exercise is safe once the incision and the tubing catheter valve system have kind of scarred into place. Interestingly enough, there's actually no published literature that directly compares shunt malfunction in athletes to those who are not athletes. Although there are a number of theoretical risks that have been raised. Notably, there's maybe decreased CSF if the patient has slit ventricles. If we go back to thinking, you know, about what happens to the brain in a head trauma with it floating in a sort of a CSF bubble. Obviously, if there's less CSF there, it may be more susceptible when trauma occurs. And then obviously there's catheter tubing in the brain, which theoretically could lead to hemorrhage in a head trauma. So again, no head-to-head studies. What people have looked at is essentially polling pediatric neurosurgeons on a large scale to see which sports they would allow patients with a shunt to play in versus which sports they would not. This is a poll of pediatric neurosurgeons across the UK. They thought that soccer and skiing were fine. They said taekwondo and rugby. About 25% said patients with shunt should not play. And similarly, there was a poll done of the 92 members of the pediatric section, and it was a similar overall response. About 1/3 said that they would allow unrestricted competition in contact sports. 2/3 said that they would not. They also asked the members of the pediatric section whether they ever remembered seeing a athlete that had a sport-related shunt complication. 23% said they had, and from that they estimated that it was probably a total of 25 to 30 complications. You know, and the math isn't perfect on this, but they figure that 92 members of the pediatric surgeon have taken care of a lot of shunt patients who played sports, and that if, you know, 25 to 30 complications was all that they could remember, it's probably relatively rare. And I do think that that's reasonable to say that a shunt-related complication in sports is relatively rare. You know, it makes sense that there would be a higher risk of inducing shunt malfunction with a direct blow to the shunt system. So, you know, perhaps sports where the participants wearing a helmet would be safer. But you know, ultimately the decision whether to play sports or not is going to be with the patient and their families. Similar to arachnoid cyst, you know, there probably is a higher risk, but that risk, at least on the best information available, is probably fairly low. And this is another condition, Chiari-1, that I came across where there's actually quite a bit in the literature about whether patients with Chiari-1 can play sports and contact sports. For me, before looking into this, would not have thought that people would withhold Chiari-1 patients from sports, but in fact, a lot would. You know, with Chiari-1, there's obviously some ambiguity about what constitutes Chiari-1, right? Some of the criteria say that if you have tonsillar descent more than 5 millimeters below the foramen magnum, that could be a Chiari. I think a lot of us tend to think of it being a Chiari only if the patient is symptomatic. And if they're symptomatic, then they should obviously undergo appropriate decompression. But there's this sort of ambiguity about what to do with the quote asymptomatic Chiari. Like, what if someone has had an MRI done or a CT done for some other unrelated reason? It shows that they have low-lying tonsils. Should they be allowed to participate normally in sports? And again, I was kind of surprised by this. You know, in the same study that I cited earlier, a lot of the pediatric neurosurgeons in the UK said no, that they shouldn't. And the reason for this is that there are a good number of case reports in the literature about people with Chiari-1, asymptomatic Chiari-1, essentially dropping dead from minor trauma, whether it be a car accident or an assault. There's no report of this happening when someone was playing sports. But I think because this has been described in minor trauma, you know, the people think that it could make participation, particularly in contact sports, more dangerous. There's this theoretical risk of brainstem compression, downward herniation that could ultimately lead to damage in the midbrain with a sudden twisting of the head or neck, or with a light blow to the head. The reality is that it's difficult to establish how likely a person with Chiari is to have a devastating neurologic injury in sports, because it's really difficult to say, number one, how many people have Chiari, and number two, how many of the people with a Chiari-1 that had these sudden neurological deteriorations after a minor trauma, how many of those can actually be attributed to the Chiari, and how could it be, how could they be sure that it wasn't something else? Because you know, there's other studies that have looked at the incidence of people and mortality rate related to minor trauma, and it's also not zero. So you know, all that we really know is that that's a pretty rare phenomenon, but that it's essentially been described. And there's a really nice study that was done on this by the group above. They essentially looked at 147 patients who they had diagnosed with Chiari, 72 of which had actually undergone surgical decompression. They followed them for several athletic seasons. You can see the breakdown. There was even one male roller hockey player, and none of those patients had any long-term neurologic problems. There's another study, again by the group at University of Michigan. They studied 308 patients over 4,600 seasons. 205 of those played contact sports. One patient experienced paresthesias, was not clearly related to the Chiari, and there were no other non-concussion neurologic symptoms, but there were 25 that had concussion, and 25 out of 300 is a pretty high number. They went back and looked at another series where they'd been studying a similar patient population without Chiari, and basically found that only 15 out of 1,000 of those experienced concussion. So 15 out of 1,000 versus 25 out of 300. So that sort of brings back to our attention this concept that if you alter CSF dynamics in a patient, you know, you may be predisposing them to a concussion. They may be more susceptible to that. And so this is something to think about, like we said, with shunts, with arachnoid cysts, and now also with Chiari. And next is epilepsy. Epilepsy is obviously a very, heterogeneous mix of conditions that can be caused by many different things. But just generally speaking, historically, clinicians have been hesitant to let people with epilepsy play sports, and specifically contact sports. And there's kind of this thought that, if head trauma can cause post-traumatic seizures, then people who already have seizures shouldn't do anything where they could have head trauma because it'll make their seizures worse. And the reality is that it's probably a little more nuanced than that. So a few things on this. Exercise-induced epilepsy has been described. It's been well reported, but overall, among all epilepsy patients, it's actually very rare. What's probably more common is that regular exercise induces the enzymes that break down anti-seizure medications. So if a patient has been inactive and they start exercising and they're on seizure meds, then they may have a seizure if their medications aren't adjusted appropriately. And there's been several large-scale studies that has actually shown that patients who exercise regularly that have epilepsy tend to have better seizure control than those who do not. And then it's sort of intuitive that the benefits overall of just regular exercise outweigh the risks. So, and another point is the vast majority of head trauma sustained in sports is minor head trauma. And there's not a link. There's never been a link described between minor head trauma and epilepsy. When we talk about post-traumatic epilepsy, that tends to be a significant head trauma, right? That's head trauma that was sustained in a high-speed motor vehicle accident, or after a significant fall, not getting hit in the head with a baseball, for instance. But it is important to think about the nature of the sport and what type of epilepsy the patient has. And a good example of this is the football player versus the cheerleader, right? If you have a seizure playing football, you're actually in a very safe place to do that. The grass tends to be very soft. You're wearing a helmet and a bunch of pads. You even got a mouthpiece in, which is like a bite block, right? Whereas if you're a cheerleader and you're like being tossed in the air and you have a seizure, then that's a much more dangerous situation. So thinking about, what type of epilepsy the patient has, is it generalized or focal? Is it well controlled? Is it not? And what sport they want to play. Those are really the things to think about when trying to advise someone with epilepsy whether they should participate in a sport or not. And I wanted to touch on craniotomies just in general. We obviously have had people do all kinds of crazy stuff after craniotomy. I just thought it was worth mentioning that there's really been no formal study to evaluate people who've gone on to either play sports or play contact sports following craniotomy. Return to play decisions have generally been very conservative. There's three principal theoretical concerns. One, obviously the bone flap being dislodged. Two, as with the other conditions we've talked about, Chiari, shunt, arachnoid cyst, after craniotomy, patients obviously have altered CSF dynamics. Are they more likely to have a brain injury related to this? And three, we know that the skin flap over craniotomy is sensitive tissue. So could repetitive trauma to that flap be problematic for the patient? And it's almost impossible to quantify, right? Because there's so many different types of grafts that are used, and so many different situations that could arise from each of those. So the only real guidance that I could give on this is CT can be helpful to look at the mineralization of the graft, and then a patient should be asymptomatic and have had abundant time for the craniotomy to heal before participating in something like sports. And the last thing I wanted to cover was some important, I think very important recommendations regarding sports and different conditions of the cervical spine. Again, continuing our theme from earlier, most injuries can be avoided with correct technique and good coaching. However, there are some people who are at high risk for spinal cord injury, and it's really, really important to recognize who those people are and to be able to stratify that risk. So, you know, the most common neurological injury that occurs with respect to the cervical spine are the neuropraxias. And there's 3 different types, and it's very important to be able to discern between the 3. On the screen's a picture of my father, who played a lot of football. He played at University of Oklahoma in the 80s, and then spent some time in the NFL. And I remember when I was growing up, obviously before I had any knowledge of neuroanatomy or pathologic conditions of the spine, he used to talk about how he would get what he called a stinger, which would be where he would you know, block someone or tackle someone, and then his whole arm would go numb. And so he wore this roll, and you can see it in the picture there on the center. He wore this roll around his neck because he said it seemed to help with that. And then the picture on the right, you know, any opportunity I have to talk about Oklahoma beating Texas University, I do. And so that's what's going on the right. But I want to come back to the symptoms that my dad was talking about, because this is very common, particularly in football. And it's important to be able to differentiate what's going on. Obviously, when someone says that their arm is going numb when they're, you know, playing a sport. And so one entity, and this is by far the most common of the cervical spine neuropraxias, is called the burner or stinger. And it's basically a brachial plexus stretch injury. It is from downward traction on the plexus. So if you think about someone tackling, right, they're going to tackle with the shoulder, and it's probably going to flex their head to one side. Sometimes it can occur with C5 weakness, but it's usually described as kind of just a burning numbness of the whole arm. And so you could see, like with my father, for instance, why having a neck roll there could actually help prevent that. It's a benign injury when it occurs, and it's not associated with any long-term neurological dysfunction. But if the symptoms last longer than a couple of hours, then that raises the concern that there's something more problematic going on. One of these things is what is kind of been referred to as burning hand syndrome, and this is kind of like a stinger, except it's bilateral. And when this happens, it's actually probably a mild central cord syndrome. So it's important to differentiate unilateral versus bilateral, because if it's a mild central cord, that's very different, and that is not benign at all. So, you know, if it's bilateral, then the patient should undergo an MRI of the neck, and then obviously if diagnosed with the central cord, they need to be treated appropriately. So you've got burner versus burning hands. And then the third is a cervical cord neuropraxia. And I kind of think of cervical cord neuropraxia as like a concussion of the cervical spine. So this will usually happen after some type of blow to the head. It could be flexing, extending, or axial. And the symptoms can vary. It can be similar to a stinger, or it could be a complete quadriparesis. It usually lasts less than a minute or two, and it generally occurs in patients with a congenitally narrowed central canal. And you know, there's some debate about this, but generally people say that if the MRI looks okay after that happens, and it's only the first time that it happened, and the patient has a stable spine, that they can return to play and not be at an overall increased risk compared to the other athletes. And this brings up an important point: cervical stenosis, right? So what do you do if someone has either incidentally diagnosed cervical stenosis or cervical stenosis diagnosed after a neuropraxia? And this is a tough one. This can be a tough one to answer. You know, obviously, if the person has cervical stenosis and they've had neurologic symptoms, if they have any cord signal changes or evidence of instability, multiple episodes of cord neopraxia, then it's pretty clear that they should not be playing contact sports. But what if they're completely asymptomatic and they have cervical stenosis? So, when we talk about cervical stenosis in sports, people tend to look at the Torg ratio or the Pavlov ratio, which is shown on the right. You just look at A over B. If it's less than 0.8, then that's considered cervical stenosis in sports. This is different from like the 10 millimeters canal diameter that we measure when we're talking about cervical myelopathy. This is specifically looking at cervical stenosis in sports. People use the Torg ratio. And essentially a lot of studies have been done on this, but a Torg ratio less than 0.8 alone is not predictive of a neurological injury. Now, a Torg ratio with any other factors, stability or previous neurological injury, those patients are at a much higher risk and should not be allowed to play. But again, just cervical stenosis alone, it has not been shown definitively to correlate with a higher risk of long-term neurological injury. And I just put together this table based on recommendations from a number of different guidelines and in large-scale publications. It's fairly intuitive, but obviously people can have C-spine fractures completely unrelated to whatever sport they want to play and want to play sports. In general, one-level fusions in the neck, foraminotomy, laminectomy. Some authors say two-level fusions, fine for contact sports. Essentially anything involving the occiput, C1, occiput to cervical spine or C1-2 fusion should not play contact sports. Patients with ossodontium or atlantoaxial instability, or if there's ever been concern that they had disruption of the PLL. It's all fairly intuitive, but I think helpful to have in a sort of table format. And the last thing, I just want to talk about competition in athletics of people with Klippel feel.
Hey, Josh, quick question.
Yeah.
Josh,
Yeah.
Alan Levy, quick question. Great summary. Congrats. I was just surprised about laminoplasty being a absolute contraindication. And what paper did you get that from?
Yeah, so
that's a non-fusion procedure, simply opens up the spinal canal and isn't associated with any sort of post-op instability per se.
Right. No, that's a great point. It was one of the I need to go back and look at what resource. I remember specifically that the argument that the author made was that there is, though it's not a non-fusion procedure, they felt that it does reduce range of motion enough to put those patients at a higher level of risk than someone with, say a 1 to 2 level fusion, but definitely, yeah, not a fusion per se, but it had more to do with whether there's a limit to the range of motion following a laminoplasty.
We know the answer to that. I mean, we've done prospective studies looking at range of motion at a year, in these patients, and it's only reduced by 30% on flexion extension radiographs. So I'm not sure that's exactly true. I think a 2-level fusion probably does about the same.
Right.
So anyways, just bringing up that point.
No, yeah, no, I definitely, I appreciate that. That's a great point. Just like I said, the last condition I wanted to review is Klippel feel. It's obviously pretty common. It's not known exactly how common. Some studies say it's as common as 1 in 200. I know we definitely see it on a lot of X-rays and CTs that we review in the clinic and on patients we operate on. The kind of classic triad described on the boards, obviously, but that's only happens about less than 50% of the time. They on the boards will usually ask about Springer's deformity as well. I've never personally seen that in a patient. There's a few classification symptoms for Klippel-Feil. I don't want to spend too much time on that because we're about out of time. But they basically they look at the number of segments that are fused and which levels. The most commonly used classification system, it seemed like from looking at the literature, is this Samartzis, which essentially there's a type 1, which is just like a complete fusion of the cervical spine. And then type 2 and 3, which is really just whether the cervical segments that are fused are contiguous with one another. Oh, and there's this slide just sort of reiterates that, you know, the paper that sort of popularized this classification scheme essentially found neck symptoms, axial neck symptoms more common with type 1 and type 2 and 3 more commonly with radicular symptoms. There's no universal guidelines for patients with Klippel-Feil, not surprisingly. There are some sort of absolute contraindications, and historically these patients have been kept out of sports. I just wanted to include this because some people have also advocated for allowing sports in a sort of carefully selected group of patients with this. Essentially, if the patient has fusion below the level of C2, and it's just, you know, 1 to 2 segments, and no subluxation or instability, then it may be safe for them to participate in sports. And I think that this makes sense based on what we know about fusions at other levels, you know, post-operatively, like we talked about on the slides before. Important to remember, though, these patients could be limited by problems with other organ systems, which are unfortunately common. And this is just some imaging that you could see in a patient with Klippel-Feil, right? And looking at the CT, you could say, well, there's maybe some stenosis there, but looking at where the fusions are, it might be safe for them to think about contact sports. But dynamic imaging is really important. You know, if you look at the X-ray, you can see that you have 2 and 3 are kind of fused, and then 3 definitely slips forward on 4. So this may not be a good person to allow to play sports. So I think we're about out of time. My kind of final word on all this, and really the reason I put the talk together, is because I think that you know, at the current you know, sort of legal medical climate, it's really easy to just kind of knee-jerk like bar people from playing sports. You know, it's extra liability you're taking on if you tell them that they can, and it's easier, I think, a lot of the time just to say no. But I think it's really important to remember that sports are a really big deal for a lot of people. I know for me, you know, growing up, really important part of development. So I would say, you know, there's not necessarily a clear-cut way to go for a lot of neurosurgical problems. I've tried to outline those here, that there at least is some guidelines or some evidence to make some reasonable recommendations. So I would encourage anybody who sees athletes to take a look at those as well. And that's all I've got.
Hi, it was fantastic. This is Jillian. I guess most of you know that we have a very comprehensive concussion program here. We were one of the first in the country to start this. We managed both counties, Miami-Dade and Palm Beach, over 60 public high schools and private schools, the Canes, and a lot of elite athletes. So now that I know that you have this fantastic interest in this, you may be called upon during football season to help us out in our clinics, because we're really busy. But just a couple points. You know, there's state legislation across the whole country. Every state has youth concussion legislation. Things have really changed over the last 5 years. You've mentioned a lot of the protocols that the pros are using, which really trickles down into the kids. And as well, you know, we have a really great vestibular group here with Dr. Hoffer, who's been doing a lot of great work with looking at goggles and other sideline objective evaluations. So all our kids get baseline tested, they get monitored throughout the season. And like, we're happy to have the help. The neuropraxis has been going to Mike Wang. And that's been, I guess, for a lot of years that I've been here and Mike's been here. But some of the more severe stuff that we're not comfortable with goes to Dr. McCrae, who actually just saw a motorized skateboard injury for us. And we're looking at that patient together because we got to get these kids back to school and back to play. So I think that's like a really great overview that you presented this morning. And we're here to all work together. And, you know, we've been managing these kids for a lot of years. And I think we do a really good job here with the program in Miami.
Awesome. Yeah, thank you. Thank you very much.